All right. Well, good afternoon, everyone. I'm really excited today to welcome you to Pulmonary Grand Rounds. We've got a good audience online and here in the Fitkin. It's my great honor and privilege to introduce Dr. Linda Haramati, who's professor of medicine in the Department of Radiology and Biomedical Imaging in the Division of Cardiovascular Imaging. And we're really pleased to welcome her back. Last year, she was here in the spring and gave a wonderful talk about pulmonary embolism and some challenges in terms of understanding that imaging. Professor Haramati obtained her bachelor's degree in chemistry with highest honors from the City University of New York, and then attended medical school at Albert Einstein, where she developed an interest in radiology. She did her internship in medicine at Maimonides Medical Center in Brooklyn, and then returned to Einstein for her residency. After a fellowship in thoracic radiology at Columbia, she returned to Einstein as a faculty member, and there, over a short period of time, rose rapidly to become professor of radiology and medicine. She was head of the Division of Cardiothoracic Radiology for over 20 years, and also fellowship director. And along the way, she also got a master's degree in clinical research methods at Einstein. In 2023, we were really fortunate to recruit Professor Haramati to Yale, where she is now professor and chief mentoring officer in the Department of Radiology. Professor Haramati is widely recognized for her clinical acumen and expertise in many different aspects of thoracic and cardiothoracic radiology. She has over almost 200 peer-reviewed articles, books, and book chapters, and she's made numerous significant contributions to the advancement of cross-sectional imaging of pulmonary diseases, and she has a particular area of expertise in the complications of HIV-related pulmonary disease. We were just talking a little bit about what it was like to be a radiologist in the Bronx at Jacobi Medical Center in the 1980s and 1990s, and how frightening it was to see lots of pathology that wasn't well understood. But over that period of time, Professor Haramati contributed to our understanding and developed great expertise that I think she'll be able to share with us today. I'd also like to just note that her career is notable for numerous professional honors and recognitions, including extensive service to journal editorial boards and national societies. She actually currently chairs the Fleischner Society Publication Development and Oversight Committee. And in 2021, she received the President's Award from the Society of Thoracic Radiology. So please join me in giving a warm welcome to Professor Haramati as she shares to us some images of tuberculosis. Thank you.
Thank you very much. It's a pleasure to be here and to share some of the 35 years of experience that I have being a radiologist, taking care of patients with tuberculosis. Okay, let's see. Mouse is going which way? This is not the best way to advance the mouse, is it?
Two ways to do it. One would be to just pull it out, and if you want to hit the arrow.
Okay,
right,
yeah,
that might
let's
be
do
the
that.
easiest.
I don't have any disclosures. So just there are a few word slides and graphs. Mycobacterium tuberculosis is an aerobic, non-motile, non-spore-forming bacillus, and it's highly resistant to drying, acid, and alcohol. And human-to-human transmission is via droplets. And each untreated person with active TB is estimated to infect 10 to 20 people per year. So obviously, it's important to make the diagnosis and stop the transmission. So I said scourge through the ages. So here is an Egyptian mummy who is an atypical mummy, a woman who died in Thebes around 600 BCE. And her mummy contained internal organs. And there was a big debate among the archaeologists of what she died from. And more recently, they noticed that she had lung amplification and used DNA amplification, lung inflammation. They noticed, and they used DNA amplification, and they found MTB in her lungs, her bone, and her gallbladder. So she had disseminated tuberculosis, which is a good potential cause for her demise. So moving ahead to our most recent estimates from the World Health Organization in 2023, there were 10.8 million cases of tuberculosis worldwide, 1.25 million deaths. So a lot of people died of tuberculosis in 2023. But we can see in the United States and Canada, there are relatively few cases compared to other regions of the world. In the United States, there were 9,633 cases in 2023, which is the most recent year that has data. And more than half of the cases were in 4 states, 22% in California, 13% in Texas, 6% in Florida, and 9% in New York, which is a neighboring state to Connecticut, but Connecticut is not a hot spot. And so that's what it is. And when we look at the TB cases incidence rates in the United States from 1993, I was already a chest radiologist at that time, to 2023, what we see is that it's really basically been a downward slope in incidence. And then since COVID, there's been an upward tick. And that could be because there was a lack of diagnosis and treatment during that time. Hopefully, things will start to go back to their downward curve soon. In the United States, as I mentioned, it's 9,633 cases in 2023, 2.9 cases per 100,000. And who in the United States gets them? 76% are among foreign-born persons from endemic countries. So that's really why the world map is so important to the United States, because most of the people who have tuberculosis in the United States come from a country where TB is endemic, and they bring it within them either as a latent TB that can reactivate, or they go home to their home country, they come back, they're visiting their friends and relatives, and they bring it with him. The other main risk factors in the United States are HIV infection and congregate living, which sounds like something nice, but it actually means that you're either in jail or a homeless shelter. So it's not so nice as it sounds. And imaging plays a crucial diagnostic role. So the rest of the talk is really going to be describing and illustrating classic radiologic cases of tuberculosis that I've encountered in my 35 years of practice. The radiographic patterns do reflect the immune status, and there are gross immune factors and there are immune factors that we don't really understand, and I'm neither a pulmonologist nor an immunologist, so I'm not going to get too much into it. But I am going to describe the primary TB pattern, which is usually seen in patients who have not, people who have not had TB before. Pleural TB, post-primary TB, either reactivation or reinfection, which have similar patterns. I'm going to touch briefly on incipient TB, miliary TB, AIDS-related TB, including classic and immune reconstitution inflammatory syndrome, and show some unusual cases and some unusual post-treatment living history types of cases. So first, primary tuberculosis. The infection is via inhalation. The PPD converts 6 to 10 weeks after infection typically. And that's an indication that the person has had a primary infection. They may or may not have a radiologic abnormality. If there is a chest X-ray abnormality, it could be anywhere in the lung, usually in the mid and lower lungs, which is where there's more lung. And it's a focal airspace opacity. Patients may or may not have lymphadenopathy, which can be unilateral or diffuse. And 90% of primary infections heal spontaneously, usually without symptoms, frequently with calcification, like within the parenchyma or within the lymph nodes, or both. And here we have a 24-year-old man who had fever. You'll see much of this imaging is old, so it's a variable ages in terms of its appearance. 24-year-old man, he had fever and cough for 4 weeks, and he had a known TB contact. And on his chest radiograph, we can appreciate that the right paratracheal stripe is widened and the right hilum is enlarged. There's splaying of the carina. This is all indicative of lymphadenopathy. There's some indistinctness of the right perihilar lung. And when we look below the diaphragm, you see that there's medial displacement of the gastric bubble, which suggests splenomegaly. This is the CT scan performed on this patient, and in that same distribution, we see paratracheal, hilar, and subcarinal lymphadenopathy. Typically, the lymph nodes are peripherally enhancing and central low attenuation, indicative of necrosis, and this is what tuberculous lymph nodes look like on contrast-enhanced CT. And we see a little bit of tree and bud nodularity in the right middle lobe, and this is a typical primary tuberculosis infection. Most of the time we see primary TB in children and not in adults. We see it very infrequently in the United States, but this is a typical example. Now, pleural TB is another kettle of fish, and the classic pleural TB, patients are acutely ill, they have cough, they have fever, they have chest pain, and they have a unilateral pleural effusion usually, and it can be moderate or large. So in the United States, if you present with a new moderate to large pleural effusion, you usually have cancer. But in places where TB is endemic and you have a moderate or a large pleural effusion, tuberculosis is a likely diagnostic consideration. And if you tap the effusion, it's lymphocyte predominant, exudate with elevated adenosine deaminase and gamma interferon. Pleural biopsy yields granulomas, but AFB smear and cultures are usually negative. And it's thought to be some kind of it's not a tuberculous empyema, but rather more an immunological reaction to a subpleural focus of parenchymal tuberculosis. And on chest X-ray, we can see parenchymal disease in about 20% and on 80% on CT. The sputum cultures are positive in about half of these patients if the sputum is carefully obtained. And we know from natural history studies, there were a lot of natural history studies of tuberculosis in the United States in the 40s and 50s. And I was lucky enough to work with Dr. Harold Keltz, who had his fluoroscopy machine in his office where he induced iatrogenic pneumothoraces to treat these patients. And he was very familiar with and introduced me to all these natural history stories. But basically, this pleural TB usually goes away on its own. And then the patients come back with more florid active pulmonary TB within the next year or two in the majority of cases. That doesn't happen nowadays when we make the diagnosis, but that was back in the day before there was anti-tuberculous therapy. This is a typical case of pleural TB, although he had a prior thoracentesis before he came for his X-ray. 37-year-old man, he had chest pain, he had fevers, he had a large pleural effusion. He had a thoracentesis, and we can see that there's a moderate to large right pleural effusion, and there are actually differential air fluid levels, which indicates that there are septations or adhesions within the pleural space. It's not one free pleural space. And we can also see that the pleura is thickened. And if you look subtly at the lungs, the left lung is clear, but there's a little bit of nodularity in the right upper lobe, which you will see much more clearly when I show you the CAT scan. So here on the CT, we see a dominant subpleural nodule in the right upper lobe with a whole bunch of little satellite nodules around it. And this is what you will typically see in someone who presents with pleural tuberculosis. We see that the gas is non-dependent within the pleural space because of the loculations, the adhesions within the pleura, and the pleura is markedly thickened in this patient. Now, what about post-primary TB? Reactivation TB, or we know now also that this can be reinfection TB, occurs in patients who have had primary TB before. They already have a developed immune response. And so the post-primary TB has a very classical appearance in people who are immunocompetent. First of all, the incidence is in about 10% of people who had primary TB that resolved on its own over a lifetime. Post-primary, usually reactivation TB, but it could be reinfection TB will occur. In patients with HIV infection, or especially if they have a very later, very advanced AIDS, the rate of reactivation or reinfection TB is very high, much higher than 10%. The radiologic findings occur in the apical and posterior segments of the upper lobes and the superior segment of the lower lobe. It can be unilateral or bilateral. We see patchy airspace opacities. Cavitation is typical. We often will see bronchogenic spread or bronchopneumonia pattern. And you can also have tracheobronchial involvement, tracheobronchial ulcers, and strictures. Bronchiectasis is a manifestation of as well, and uncommonly pneumothorax. So this is a typical example of a fairly advanced case of post-primary tuberculosis in a 39-year-old man who presented with cough and fever and weight loss. And we can see that there's bilateral upper lobe predominant disease. We see a big cavity in the left upper lobe with volume loss. We see these kind of acinar shadows and confluent opacities in the right lung and the thick-walled cavity in the right upper lobe. On CT, we can appreciate the areas of consolidation as well as bilateral thick-walled cavities, and very little in the way of lymphadenopathy. Lymphadenopathy is not a feature of post-primary tuberculosis. This is another example, a 61-year-old woman from Africa. So she's from an endemic country. She's HIV negative, but she has this thick-walled cavity. It's in the superior segment of the lower lobe, possibly straddling the fissure. We see some patchy airspace opacities as well in the left lower lobe and to a lesser extent on the right. On her CAT scan, again, we see this big, thick-walled cavity with mural nodularity in the superior segment of the lower lobe. And we see confluent airspace opacities and ill-defined nodules bilaterally left greater than right. We also can appreciate a calcified granuloma in the left apex. So she had her primary TB a while ago, and then she developed this reactivation or reinfection tuberculosis that presented as her clinical illness. And this is a very common way that TB presents in endemic countries. Okay, moving on to incipient TB. So the incipient TB is a new concept, newish concept, somewhere between the primary infection and the florid post-primary clinical presentation. There, we talked a lot about reactivation tuberculosis in my younger days. You had TB, your body contained the infection, and you were fine. But the organisms are still alive within your body if you haven't received anti-tuberculous therapy. And so somewhere in between the primary infection and when you get florid, clinically presenting disease, you can have kind of an indolent active infection that is tuberculosis. And in those cases, it can be a primary infection, it can be a reinfection, it could be reactivation, but patients are not sick. And they have nodules or tree and bud opacities, tubular branching opacities. It can look like cancer. A lot of these patients are not worked up for infection because they are not clinically presenting as infection. This patient underwent a PET scan. A lot of times this is what happens. It was FDG avid, it was resected, it's a granuloma, it's tuberculosis. And so this is we know more about this now because we do more imaging all the time in every way, shape, and form. And so it's not quiescent, but it's not floridly, active either. It's this incipient intermediate form of tuberculosis. And it's a cause of false positive PET scans because they're metabolically active. And in places where there's a lot of people with risk factors for tuberculosis, it's a fairly common cause for lung resection for non-cancers. Here we have an 80-year-old woman. She fell down. She came to the emergency room in the Bronx, and she has no consolidation. But if you actually look closely, she has many little nodules in her lungs bilaterally. And an astute radiologist picked that up. And she had a chest CT, which shows a diffuse miliary pattern. This is miliary tuberculosis. And so miliary tuberculosis or disseminated tuberculosis, it's obviously more common in patients who have florid diminution in immunity, like patients with advanced HIV infection or cancers. But we know that miliary TB can present, with increasing age as a risk factor. It can be for no apparent reason that we know of, or it's poorly understood. In fact, there was a very, very famous historical figure who died of miliary tuberculosis in the last century, the wife of a president. Does anyone know? Eleanor Roosevelt, right? And everybody thought she died of cancer. She was wasting, she languished, and on autopsy, she had miliary tuberculosis. So switching gears to talk about TB and AIDS. So classically, the diminution in T cell function increases the susceptibility to tuberculosis infection. So even in well-controlled HIV infection, there's an increased risk for tuberculosis. But as the immunity wanes during the natural course of HIV infection untreated, the susceptibility to tuberculosis becomes very, very, very high. When someone's infected, they don't get like a primary infection that becomes quiescent. They're much more likely to develop active disease. And the thing about HIV-related TB is that the radiographic findings vary with the immune status. They very uncommon to have like typical reactivation type disease. Cavitation basically doesn't occur when the CD4 count is below 200. They more commonly will have disseminated disease, lymphadenopathy, what they call atypical infiltrates, meaning opacities in areas that are not the apical posterior segment of the upper lobe, superior segment of the lower lobe. So everything about like AIDS-related TB, when the immunity has waned a lot, it makes it very difficult to diagnose, except you have to have a high index of suspicion. Some of these cases are really from way back in the day. This is a 39-year-old with AIDS who had a low CD4 count. And he has extensive adenopathy, paratracheal and hilar adenopathy. And these look like cannonball masses, large bilateral masses in the lungs. This is his chest CT, extremely large bilateral masses as well as nodules, no cavitation. His hilar look prominent. I'm going to show you the mediastinum in a minute. He has extensive right hilar. He has bilateral mediastinal lymphadenopathy. This is a non-contrast chest CT, and you can see that his myocardium is much higher attenuation than the blood pool because he has severe anemia. And these are images from his contrast-enhanced abdominal CT, where we see the typical necrotic adenopathy, central low attenuation, and peripheral enhancing. And this was disseminated tuberculosis. This is a 48-year-old man. He had AIDS. He had a very low CD4 count. You see that he has diffuse pulmonary opacities that has a bit of an upper lung predominance. It's mostly nodular. We don't see consolidation. We don't see cavitation. One thing you can see if you look very closely is that there's asymmetry in the neck soft tissues, which are more prominent on the left than on the right. On his CT, that we can see that is due to this big left neck lymphadenopathy. He also has multiple lesions in his brain, some of them ring enhancing, and he has extensive pulmonary opacity. Some of them are nodules. This is not the same type of miliary TB that we saw in that old lady who was relatively immunologically intact. In this case, the nodules were like, first of all, they were far more numerous and they're extremely ill-defined, and we see areas of confluence. So even though this was a case of disseminated tuberculosis, it didn't have that classic sharply defined millet seed type of appearance, but rather some other atypical finding that this is all tuberculosis. So paradoxical response was initially described soon after anti-tuberculous therapy came out in the 1950s as a transient worsening in symptoms and radiographic findings after anti-TB treatment was started. And that was thought to be due to like the immunity, basically, we have immunologists in here, but basically it's thought to be the immunity kind of getting a handle on the infection and the consequent inflammation. This is a radiologist's view of things. And immune reconstitution inflammatory syndrome in HIV infection is a similar process, at least in terms of the presentation. They typically have, okay, this immune reconstitution inflammatory syndrome is not specific to tuberculosis. It can occur with other infections in HIV infection where antiretroviral therapy is started. It was initially, we saw it more with MAC, but it occurs in TB. And it's actually, that's where it's like a clinically important, I think, right now in care. Worsening of TB symptoms and radiographic findings occur when antiretroviral therapy is started. And it can also, it can be like in cases of known TB that was diagnosed, or there can be an occult infection. And when you start antiretroviral therapy, these symptoms develop and the infection emerges. So it's emergence of occult infection, or it can occur in the setting of known infection with antiretroviral therapy. So there's a whole literature that you pulmonologists probably know a lot more about than I do about optimizing the timing of anti-tuberculosis and antiretroviral therapy to reduce the chances of this happening. This is these cases that are from the literature, also from my practice, I just published some of them. This is a 47-year-old man with AIDS with disseminated tuberculosis. His CD4 was 51. He had bilateral extensive pleural effusions and lymphadenopathy on his portable radiograph. He started antiretroviral therapy, marked worsening of symptoms as the CD4 count went up. The adenopathy became worse. The pleural effusions became bigger. And it's not just the timing. You have to be aware of the timing, but these patients often will get like extremely well worked up. They get tissue samples, they get fluids, everything is sampled and nothing comes back positive. It's not like a new infection or a lymphoma developing upon tuberculosis, but it's actually the inflammatory response. Okay, now transitioning to complications and sequela of TB. So this is going to be some of the less common manifestations of tuberculosis. I'm going to touch upon bronchopleural fistula, esophageal fistula, pericardial disease, aspergilloma, Rasmussen's aneurysm, and Pott's disease. So bronchopleural fistula can occur in tuberculosis due to a rupture of a cavity into the pleura or iatrogenic. For example, like tapping a tuberculous effusion that gets into a abnormal lung parenchyma, and that bronchopleural fistula will not heal. It can have a very high mortality due to toxicity and spread of the disease from the parenchyma into the pleura, from the cavitary infection. You can develop a tension pneumothorax. In the chronic phase, it can have high mortality due to multiple foci of infection, aspiration of empyema fluid. It's a tricky disease, even with proper medical therapy, although it's obviously gotten a lot better as time has gone on. This is a case from my practice. I read so many x-rays on this poor man, 38-year-old man from India. He was HIV negative. He had a normal, had normal immunity when he came in. He had bilateral, typical post-primary reactivation type TB pattern. He was cachectic, he was sick, and he developed a bronchopleural fistula and this tension, this pneumothorax, which developed tension. He had pan-sensitive tuberculosis. He was being treated, he was being nutritionally repleted, and he still died from tuberculosis. It was terrible, terrible, terrible case. He languished in the hospital and we were unable to, he couldn't recover. Esophageal mediastinal fistula. So TB, because of there's a lot of necrosis and tuberculosis. So you get fistulas to different places. Esophageal involvement per se, like TB of the esophagus, is rare. So usually it's due to secondary involvement by the adjacent subcarinal lymph nodes. And that is actually the most common cause of diverticula in the mid-esophagus back in the day was because of tuberculous lymphadenitis causing traction of the esophagus. But you can also have strictures, esophageal strictures, tracheobronchial or mediastinal fistulas, and the patients have fever, they can have cough, they can have weight loss, dysphagia, discomfort, back pain. Most common region is the subcarinal region, which is really intimate with the esophagus. And this is a 38-year-old man with AIDS who had tuberculosis. So, okay, I snapped this slide with my camera back in the day and then scanned it. And it's not the most beautiful, but it really, you needed a bright light to see it at the time. And we see these tree and bud nodules and confluent opacities bilaterally more on the right. There's subcarinal adenopathy, and the right hilum, it's very dense, but it's the hilum overlay sign. So that means that it's either in front of or behind the hilum, and mostly not hilar adenopathy. He went on to have an esophagram, and we see this fistula from the esophagus into the subcarinal region. This is subcarinal adenopathy. We did the CAT scan shortly thereafter. The esophagus also wasn't working properly, so the contrast was stuck in there. And we see the confluent opacities in the right lower lobe as well as in the right middle lobe. These patients with late stage AIDS, as this patient, they don't have cavitation and tuberculosis. They have cavitary fungal disease. Other things can cavitate. Bacterial pneumonia cavitates, but for some reason, TB like never cavitates when the immunity is very low from tuberculosis. Pericardial TB. So pericardial TB, so the pericardium, the heart, the lungs, the esophagus, the lymph nodes, they're all in the same vicinity as each other. So it's surprising that we don't see actually a lot more pericardial TB, but we do see some. And it can be from direct extension from the adjacent lung or from adjacent lymph nodes or possibly from adjacent pleura. It's often lymphohematogenous spread, but it can be direct spread. You can have pericardial thickening with or without effusion. Later on, if you have tuberculous pericarditis and it heals, you can have pericardial calcifications. Tamponade is rare, but if you have pericardial TB, the natural history is about 10% of cases will develop constriction and 90% will not. So it's not inevitable in terms of natural history, but it is obviously a risk, and you would rather not have that. So this is an older gentleman without immune compromise, but he has this globularly enlarged cardiac silhouette. So for a radiologist, that means that either it's multi-chamber cardiomegaly or there's a pericardial effusion. And a simple sign that people don't talk about that really can help you distinguish one from the other on a portable radiograph is the hyla, right? So the hyla are the pulmonary arteries on a chest X-ray. And when you have cardiomegaly, the pulmonary arteries usually get pushed out. They're like kind of the central cardiovascular structures. Whereas when you have a pericardial effusion, the pulmonary arteries are tucked in. So, and you'll see, it really works. This is like a sign that really works that nobody talks about. So here we see this globularly enlarged heart, the hyla are tucked in, and he has a fairly large pericardial effusion, small pleural effusions, and this was pericardial tuberculosis in an older gentleman. I'm going to show you some other unusual cases of pericardial TB. This is a 30-year-old HIV positive CD4 of 17 who had multi-drug resistant TB, and she had a chest X-ray which showed a new pneumopericardium. This is a pneumopericardium. We see gas within the pericardium. It's stopping at the top of where the pericardial recess is. The pericardium normally is very thin. Here it's markedly thickened, and we see some septations within it. She went for a CAT scan, and again, here we can see the pneumopericardium going in between the pericardial recesses, and it's due to a bronchopericardial fistula in the setting of multi-drug resistant active TB. We also see many other pulmonary nodules in this patient. It was a big dilemma what to do with this patient, but there were medicines that could treat her TB, and the decision was made to treat her medically. And slowly, she got better. So there was resolution of the bronchopericardial fistula. If you had intervened, it is entirely possible that she would have gotten a lot worse before she got better, or maybe wouldn't have gotten better, but the medicine did the trick for her. So thank goodness for that. Of course.
Patient like that at risk for constrictive myocarditis experience.
I don't have that many experiences like that, like this. I mean, all of these, well, she had advanced HIV. So in her case, like her life expectancy, at least at that time, was pretty low. But they're all at risk for constriction, but it's not inevitable. And they treat nowadays, I think, with colchicine, right? It's just playing the odds, reducing the odds of something bad happening while trying not to create something bad. With TB, what I've seen in the patients that I've imaged, the more interventions you do, the worse off you are. And the best treatment is almost always something that has to do with medicine, and almost never something to do with, surgical intervention, at least nowadays, now that we have medicine that treats tuberculosis. This is another patient with tuberculosis. Surprisingly, they all do. 26 years old. He doesn't have HIV. He came from South America. He had night sweats and fever. He had bilateral pleural effusions, and he has cardiomegaly. On his CT, I already gave you the diagnosis here, but everybody has TB. So we see that there are bilateral pleural effusions. The right effusion was tapped, and we can see the pleural thickening and loculation. The left effusion had not yet been tapped, but it was thickened. We also see these really weird extrapleural lymph nodes and lymph nodes in the cardiophrenic recess. There's pericardial thickening and pericardial effusion. We can see that there's peritoneal fluid, peritoneal thickening, and also omental caking and mesenteric lymphadenopathy, and also thickening of the colon. So there's everywhere we look, there's something going on. They actually biopsied the omentum. It came back granulomas, and then they tapped the effusion. It was lymphocytic, and then they're like, we're pretty sure he has lymphoma. And I'm like, but he has all these granulomas and he's sick. And I'm like, you better start treating him for TB while you're like completing your workup, because this is like, you might be missing the boat if you keep biopsying things and you're never getting lymphoma, which is what was going on. And this was a disseminated lymphohematogenous TB. He's a young man. He came from an endemic area, but he wasn't, like, to our knowledge, immunocompromised. He had a workup, which was negative, but obviously he had some kind of terrible tuberculosis. Okay, aspergillomas. Okay, what I'm saying here may not exactly be right. Approximately 25 to 55% of patients with aspergilloma have a history of chronic cavitary tuberculosis. So that is historical. And I think it depends on where you are geographically. Nowadays, most people with aspergilloma have sarcoid as their primary cavitary, cystic sarcoid with cavities and aspergilloma. But if you're from a place where there's a lot of TB, it's a big risk factor for development of aspergilloma. Hemoptysis is the most common complication. And the radiology findings of aspergilloma, basically you're going to have the findings of chronic, treated tuberculosis with bronchiectasis or residual cavitation. You need to have something residual there to get an aspergilloma. And then you can have thickening of the wall of the cavity, and then you can have mural nodularity, and eventually you develop a soft tissue mass within the cavity that moves, that is like mobile. There's the Monod sign, gas surrounding the mycetoma, or the air crescent sign if it moves with gravity. This is a doctor who developed TB at work, unfortunately. And she was treated, and we can see that there's bronchiectasis and volume loss and maybe a little cavitation in her right apex. The hilum is retracted. 2 years later, we see that there's thickening of the wall of the cavity and there's mural nodularity. And this is what it looks like on the CAT scan. So the nodule is not dependent yet, but there is wall thickening and mural nodularity, and this was an aspergilloma. Okay, this is one of the most dreaded complications of tuberculosis, Rasmussen aneurysm. It's rare, it's weakening of the pulmonary artery wall from adjacent cavitary tuberculosis. And by weakening, I mean disruption. This is an infected pseudoaneurysm. Hemoptysis is usually the presenting symptom, and it's life-threatening. It's usually life-ending. Most people with Rasmussen's aneurysm, unfortunately, do not survive the experience. And this is a 47-year-old man with AIDS, with tuberculosis, with hemoptysis. And we can see this large Rasmussen's aneurysm within the right lower lobe, which is consolidated and has blood within it. And here we can see the connection to the pulmonary artery. He had a pulmonary angiogram. We see that it right away fills with blood because it's in the pulmonary artery phase. It's a pseudoaneurysm, and which is a contained rupture of the pulmonary artery with infected material around it. They attempted embolization, didn't work, and the patient unfortunately passed away. Pott's disease is tuberculous spondylitis. This also used to be something fairly common. My mother talks about it. All these people who used to walk around bent over at a right angle. Now some of them may have had osteoporotic fractures, but a lot of them were due to tuberculous spondylitis, which is usually spread to the spine hematogenously. On a chest X-ray, you can see paraspinal mass, end plate irregularity, decreased disc height and sclerosis of adjacent bones, and later on, paravertebral abscess, anterior wedging, and acute angle kyphosis. And this is a patient with Pott's disease. This is the chest X-ray. We can appreciate some pulmonary opacities, but they're very subtle. We also see this paraspinal opacity. I'm going to blow it up for you so that you can see it better. We see that here. We also see something funny going on with the vertebrae, right? Vertebrae, and then some things not looking right here. And this is a paraspinal abscess. We see that there's fragmentation of the vertebrae. And the lungs have diffuse tree and bud nodularity. This is bronchogenic spread of tuberculosis pattern, although he has Pott's disease, so he also has obviously some hematogenous spread to his bone, her bone. So moving on to living history, I hope I have some time to show you. I'm going to talk a little bit about collapse therapy and some unusual patterns of recurrence. So my first slide is that TB is an aerobic organism. So before there was anti-tuberculous therapy, but it was already like the 1800s and the 1900s, we had like the fresh air cure. We had the TB sanitariums, and then there was collapse therapy. So the most common collapse therapy is people with TB would go to their doctor, they go under a fluoro machine. Like I said, Dr. Keltz used to do this, the late great Dr. Harold Keltz. They would induce a pneumothorax, and the patient would keep coming back over and over again to get their lung collapsed, and that deprived the organism of oxygen, and it gave the immunity a chance to win the fight against tuberculosis, as opposed to in the opera where everybody dies of tuberculosis. So this is a patient, 57 years old. She had collapse therapy for tuberculosis. This is a pretty classic appearance of a tuberculous fibrothorax after collapse therapy. The hemithorax is small. Sometimes you have more aeration, sometimes you have less aeration, but it's always small, and the pleura is always calcified, and the mediastinum is always shifted towards that side. And then we see signs of prior TB in the left lung. This patient did not get anti-tuberculous medicine because they got collapse therapy. It was from before. And she developed this bump in her right anterior chest, right here. And we see that there's extrusion of the calcified pleura into this bump, which was sampled, and it was a reactivation tuberculosis in her fibrothorax. She had what's called a cold abscess. Tuberculous abscesses are cold as opposed to pyogenic abscesses that are, you know, Calor, Rubor, Dolor, whatever, all those things. This tuberculous abscess, just a bump. It's nice and cold. So this is an example of reactivation in a fibrothorax. Everyone who had collapse therapy is at risk for reactivation. There just aren't that many people like that anymore. 88-year-old man, he had collapse therapy. This is a scout from a CAT scan, but we can see the classical fibrothorax. We see a little bit of gas within the right hemithorax. The mediastinum is shifted to the right, but not quite so much as our other patient. And that is because there's a lot of fluid within the fibrothorax. And this is also reactivation of tuberculosis within the fibrothorax. And it developed a bronchofibrothorax pleural fistula. You can also get superinfection with bacteria inside of a fibrothorax. And they're also at risk because of the chronic inflammation, or I'm waving my hands here because of not fully understanding of a malignancy, lymphoma, and lung cancer and other malignancies. So this is a case of reactivation TB in fibrothorax. This person had a thoracoplasty. This was one of the most brutal of the collapse therapies. They basically broke a whole bunch of ribs and pushed the chest right in to collapse the lung permanently. She obviously was also cured of her tuberculosis. She didn't reactivate. We see signs of TB on the other side, calcified granulomas and some mosaic attenuation, but you can see the effects of the fibrothorax and the appearance within the chest. So it led to deformity, but she lived many, many, many decades after her TB treatment. This is someone who had an Ellewesser thoracostomy, also called an Ellewesser flap, which is like a living chest tube for treating of underlying TB. You can see the whole right lung is bronchiectatic and with cavitation from tuberculosis. So you would do that in a case where someone had an intractable, for example, bronchopleural fistula that wouldn't heal, to drain it into the outside world. That would be probably the most common reason to do one of these things. And this also, it worked. And she lived to an older age. This is an 81-year-old man. He had plombage, which is when they put those lucite balls into the extrapleural space to collapse the lung over time. These used to be homogeneously radiopaque. They developed these air fluid levels because they degenerated, but the lung is still collapsed underneath the TB. But this patient also, so this is what the plombage looks like on a CAT scan, but they also have this big anterior mediastinal mass, as you can see on the sagittal. And this is a case of poorly differentiated adenocarcinoma of the lung. So presented with primarily a mediastinal mass, but it was a lung cancer. And there is a relationship, as I mentioned, between prior TB and lung cancer and lymphoma. So that's another thing to, just to be cognizant of, is the increased risk. So in conclusion, TB remains a global scourge. In the United States, it's most common in foreign-born HIV and, of course, our favorite congregate living. I've reviewed here the primary, pleural, post-primary AIDS-related tuberculosis. They have typical findings. Each patient with active TB infects 10 to 20 people per year. We want to make the diagnosis in order to help that patient and to stop the transmission to other people. Also, recognition of usual, uncommon, and rare imaging findings is crucial to the diagnosis and initiation of appropriate treatment. Thank you.
For the fantastic talk. So we'll open it up to questions now in the room and also online. My question, I think you kind of answered at the end, but I'd just be curious to hear your thoughts a little bit. I know there's no answer to this question, but as you alluded to, lung cancer 2 to 3-fold, I think, increased risk in people with a history of tuberculosis. And I know you showed some really severe cases of folks with collapsed lung and never got therapy, but I think where it comes up is we often see patients with solitary pulmonary nodules, and maybe they have a risk factor for tuberculosis. And the TB doctors always say, treat empirically and then re-image and see if they get better. And the interventional pulmonologists always say, sample it. And I'm just curious, in your experience, is there time to kind of allow people to have a trial of empirical therapy before kind of moving ahead, or is it better to move quickly?
In my experience, a lot depends on like the practice that you're in. And the variations in practice have a lot to do with the TB prevalence. So if TB is highly prevalent in your population, then, the calculus weighs more in favor of possibly of doing empiric therapy. And that's where they're going to do it more often, I think. I think if you have interventional pulmonology and they can sample it and make a benign diagnosis, this is a pulmonary crowd. Making a benign diagnosis or a specific infectious diagnosis is not so easy with small samples. And the least ideal thing to do is to take out an infection. You could say, oh, the patients write about this in the newspaper all the time. I was so scared and I had this nodule and they took it out and I was so lucky. It's not cancer. No, that's not lucky. You didn't need your nodule removed. But so, there's a balance, and, it depends on expertise and how likely you think you'll be able to make a non-cancer diagnosis and how prevalent TB is.
Thanks. That's very wise. Ed.
Hi, thank you for the wonderful talk. I graduated from Einstein. I'm sorry I didn't have the pleasure of meeting you there, but I'm glad to meet you now. I'm a pulmonologist, and in current generation of training in a non-endemic area, we tend to see reports of like rule out TB or possibly TB on many radiology reports. So we may have a tendency to kind of dismiss that as practitioners or put it to the back of the mind. I'm wondering if there were actually any studies that have shown in isolation what the positive predictive value is for radiology, like potential diagnosis of tuberculosis, if we were to do no other workups.
Are you talking about like people who have positive PPD that were doing a screening X-ray? Or are you talking about people who have like some severe findings and TB is in the differential diagnosis?
More like if there's any severe findings or even both. I'm just curious.
Okay, so the pre-test probability determines everything, right? And then the post-test probability is only slightly altered by the test result. Mm-hmm. So if we have an imaging, if the pre-test probability is vanishingly small because we are in a, we have no risk factors, they're not from an endemic area, they don't have HIV infection, they didn't just come out of their homeless shelter, then the chances of it being TB is very low, regardless of what the results of the X-ray are going to be. Mm-hmm. So it's like, this is why we have to work together, like kind of in aggregate. If you use the imaging in isolation, then it's not, it's not really going to be that useful in helping manage the patient.
No, thank you. That's because we often are faced with this and make the same comments.
We're also faced with this. We work in this, we work in this environment where, it's basically, working off a list. We don't have the luxury of rounding with you guys and talking about the cases and, trying to problem solve or troubleshoot together. Like in my younger practice, I used to meet with the pulmonologists. We would round every day on our patients. We don't have that discussion now. Nobody in the United States practices like that anymore because it's, we don't have sufficient resources to do that. But, an X-ray result or a CAT scan result has to be put into context.
Thank you.
Clar?
You have to turn it on. Yeah. Thank you so much for sharing those wonderful images. I think what's so interesting as you were going through there is I think you were linking various patterns to immune status and so forth, and sort of thinking pathophysiologically what is going on. I just want to clarify something with miliary TB. I think you said it's related to disseminated, but is that a pattern of hematogenous spread of infection to the lung?
Yes, it's thought to be a pattern of
sense.
hematogenous spread, but it's not just to the lung. If you have miliary TB, it's disseminated.
It's disseminated throughout the body.
Yes.
But it's from the blood creating that pattern in
That,
the lungs.
it's from the blood. You can have metastases that look like that too, that are like hematogenous mets.
Okay.
So it's not specific to TB, but it's a miliary pattern.
I see.
Those patients usually have like TB in their liver and other organs.
Got it. Got it. And the other question I have maybe to the group are for folks who practice, who see more TB patients. But the other thing that you mentioned that I think that's changed since I trained is we always linked adenosine deaminase with this, but are we checking gamma interferon in the pleural fluid now for patients? Is that something that is clinically available?
I don't think it's available at Yale New Haven Hospital, but that is the best, as far as I know, sensitive test. Sebastian, have you had any situations come up since you've been here where we'd order it, or others in the room? I think we could probably get it as a send-out test, but I don't think we have it at Yale.
No, I haven't. And actually, my next question is, how about the ADA? Are we able to get that?
Yes. Yes.
We're fortunate to have obviously great interventional pulmonary service, and you don't have to struggle to do blind pleural biopsies as the way some of us had to do in the past. Eva?
Hi, thank you so much for this talk. I'm a medical student, so I apologize to others in the room who are much more experienced. When you're looking at a cavitary lesion, sort of without a lot of knowledge of the patient's context, how do you go about differentiating radiologically between TB, a bacterial pneumonia, other causes of cavitation?
So I think that, for us, it's always a differential diagnosis that you think about in your mind. Do they have TB? Do they have like a lung abscess or a necrotizing, bacterial infection? Do they have cancer? Do they have something else like, rheumatoid, cavitary rheumatoid nodules or whatever. So again, it's, putting it in the clinical context. Or if they have classical consolidation in the apical and posterior segment of the upper lobe or superior segment of the lower lobe, if they have HIV infection, if they have fevers and night sweats, it would rise it higher. I mean, we don't have pulmonary rounds, but we do have EPIC. So we do look in the notes to try to help guide us.
I'm also a med student, so sorry if this is silly, but what % of the time are you doing radiographic imaging among people who have TB and don't see anything? And at what point do you as like the radiologist shift treatment away from empirical therapy and say we need something else?
Well, do they empirically treat people with negative X-rays?
Well, for sure, people with HIV can very commonly have negative X-rays. And so with CT imaging, I would say, that's 100% negative predictive value if you don't see anything on CT imaging. For pulmonary TB, you might have to think about other sources of TB. But for the chest X-ray, you have to be very suspicious. And in a study that we did in Uganda, 21% of our population of advanced HIV had normal X-rays read by a radiologist. So you have to have a higher index of suspicion in those settings. And, in those settings, I think also now ultrasound is an exciting new tool that we have access to that can give us information not only about pulmonary TB, but about extrapulmonary TB. And I think some folks at Yale are working on trying to use artificial intelligence in that sense to kind of make that accessible. So great question.
All kinds of cool things out there.
Yeah. Well, please join me in just thanking Linda for an outstanding talk and the great images. And thanks for coming back.